Ok, that's fine.
No.
Scusa,
Niente.
non c'è nessun modo.
No, con quelle no.
Ci vorrebbe sul microfono.
You can proceed the slides with the button on the left.
The button, okay, I see it, I can see it. So, just to give a very small introduction to the problem, as a matter of fact, when you're dealing with anterior column reconstruction, you're always scared about the fact that you will not be able to do it just by a posterior approach. Well, you're scared, why? Because we do not like, as I think everybody else, to perform a double operation, and mostly in the lower thoracic spine and in the upper lumbar spine, going by anterior reconstruction of the spine, it's a demanding procedure with plenty of risk. So, looking at the literature, we have been encouraged, looking at some paper coming from the United States and from India also, we have been encouraged in trying to substitute the vertebral body, which is the main problem in case of trauma or metastatic tumor, coming just by a completely posterior and posterolateral approach. So the webinar should be about posterior vertebrectomy for anterior column restoration in spinal trauma and metastatic tumors. Are you following me? Can you follow me? Non c'è risposta. Can you hear me?
Sì, sì, si
Okay.
sta seguendo.
Surgery, as usual, would accomplish the main task of performing a decompression of the neurological structure and stabilization, which in many cases will require, beside the standard fixation and fusion, also anterior column reconstruction. And this is completely necessary because you very well know that the 75% of the load is in the anterior column, not in the posterior one, and just the posterior fusion cannot be enough to restore the spinal balance and solidity. And as you see here, to perform posterior stabilization, it's simple, common, everybody is doing it. We try to explore the chance to rebuild the anterior column, and we've been encouraged by the literature. And most of the paper dealing with the subject that you which are not really describing so many cases, because the largest one are talking about 30 cases. And the most encouraging papers, all of them came out after 2015. They based the chance of exploring this new approach, considering the high risk of anterior approach, the longer operative time with higher perioperative complication, and the very long hospital stay of this patient. So, transpedicular corpectomy, it's a sort of standard procedure. On the other hand, the positioning of an expandable cage by posterior approach is not so standard, because you have many cases that need and the chance to sacrifice spinal root in the thoracic region and or even in the lumbar region. And there have been plenty of papers talking about the risk of having some abdominal prolapse if you're sectioning the lower thoracic spinal roots, and at the same time you can have a severe deficit if you're injuring the L5 spinal root. So the procedure is risky. At the same time, you have no such a wide room, and you need also to work a bit in a blind condition, because as far as you're working in front of the dural sac, as a matter of fact, you're not controlling so much what you're doing on the bone. Here you see some of the alternative treatment, such as lateral extracavitary approach. And this was, as a matter of fact, the first paper which came out. It was by Resnick and Benzel, that many of you may probably knew. I know them very well. And this was done, this was presented already in 1998. So the idea came out very early. Nevertheless, the paper which have consolidated the idea that this was possible and the result could be good during the last 10-15 years. The technique is fairly simple. You are mostly exposing just in the case of the posterior approach, the lateral portion of the spine, and you're not forced in any case to perform a bilateral exposure of the dural sac. On the contrary, if you go anteriorly, you have to deal with plenty of functional important structures such as vessel, the aorta, the venous vessels. So there are a lot of reasons in favor of the posterior approach, in spite of the fact that the room is narrow and still you have the risk, maybe a higher risk of damaging the spinal cord. Here you see how the procedure can be performed by a combined anterior and posterior approach, or just by a posterior approach. Transpedicular corpectomy can get some advantage by navigation, because what is very difficult to establish is how deep you are in the vertebral body, how near you are to the anterior surface of the dural sac, how complete has been the removal of the portion that you planned to remove of the vertebral body. And also the positioning of the expandable cage, it's crucial, the way you position it, because you have to always consider the chance to damage the lower spinal root that is involved in the technique. Here you see just to look at a case when the posterior fixation alone couldn't be enough. This is a post-traumatic fracture in a young guy. It is quite clear that, and it was a quite unstable case, it's quite clear that posterior fixation will fail. This is the starting of the description of the technique. As you see here, it's not really needed. This is the case you have seen before. It's not needed to expose bilaterally. What you see here is something which is crucial. That is, you have already positioned your pedicle screws, and now you're using a spatial spreader which is completely offset from the operative field, and which is distracting by means of the pedicle screw itself. Now I let Francesco tell something more about the technique.
Good evening to everybody. And
Yes.
in this picture, do you hear me? Okay. In this part, you can see that in case that you don't need to perform a bilateral decompression, we can perform a monolateral approach. In this way, we can preserve the posterior element like spinous process and ligament that helps in stabilization. The spreader that Dr. Fornari have shown you allow to distract without any rod in through the final canal, and we have this area that is our exposure. In the midline here we can see the dural sac, and this is the area of pedunculotomy, and we have to perform two extralateral approaches to the nerve root that give us the access to the disc. The next, we can see the spreader that is put on the pedicle screw, and we can distart. On the other side, if we want, we can put a standard rod, but on the side where we can work, where we have to work, we have to use this spreader that allows us really to enlarge the space. This is the pointer that allows us to control the position of the disc, the depth of our decompression and corpectomy, and the direction on the contralateral access to the vertebral body. Here some intraoperative imaging. We can see here and here the disc space and the discectomy. This is the nerve root, and here what we can see with navigation. With our passive frame we can verify how we are deep, if we are enough anterior to the decompression in order to have enough space for the cages, and to verify if our angle is enough for the cage positioning. This is some other surgical step. With the micro drill we remove first of all the pedicle, and after we go through the vertebral body to remove it with Carrison and high-speed drill for sure. Yes, when we are using the high-speed drill, we have to protect the nerve root, that the lower nerve root, because is just behind is just near the disc and the pedicle, so we have to protect in order to avoid any disruption by the high-speed drill. With the pointer we check step by step our progression, and this is an advanced phase of corpectomy. Finally, when the area of corpectomy is enough, we can use this probe that allows us to define the dimension of the end plates and give us the idea of the positioning, what is the angle to the cage insertion. That is the most critical part of this surgery. Here is some instruments, not all like this, that can give us the possible of to change the angle. This is a new version that we don't use right now. The other that we use is just linear, straight, so we have to angle our instrument. So we in this phase we need to change and to angle bilaterally in order to go in the midline. And this is some example on what we are doing. If you can see here with the monolateral approach, we have the below nerve root that is in the position, because the disc space is just under the nerve root, so we have to the end plate and the disc that we have removed, so we have to protect and we have to gently stress. But when we go with the cage that you can see here, that is very huge, because we have to reconstruct and to use the bigger end plate as possible to perform a better load sharing. You can see that the space is really narrow, so the retractor is really a critical part to protect the nerve root and the dural sac. With this, yes, you can see from this position and the second position that we insert first of all this part under the nerve root, and after we can rotate the cage on the upper part, because the nerve root, the upper nerve root, is more higher and rarely is really difficult. And after that we are in the space, we can rotate the instrument. You can see that in that part is from midline to the lateral part, and finally when we go under the nerve root, we rotate in order to gain the midline with the cage. So with this instrument that cannot change the position of the cage, but we will see that in the future this instrument can be changed. We have to stress the angulation, and in this part you can see that we go to the midline under the dural sac, and the nerve root is just free near the instrument. And this is the final that after the X-ray control that verify that our expansion of the cage, the position is good, we remove it, and this is the final field with the dural sac, the nerve root that go over the cage. So in the upper thoracic part, if necessary, we can think to clip the nerve root, to section the nerve root, and in this way we have a huge space and is really more easy. From T9 to S1 is not suitable, this option, so the retraction is very, very important. In my opinion, it's very important to perform an exposure of the nerve root also outside of the spine, because this can give us the possibility to have a gentle rotation and to free the nerve root from to displace more in the midline. So it's very important also to perform the dissection from vessels in order really to have a gentle retraction. And as I stress, the cage right now we have to position in oblique position, and have to perform a rotation of it, and finally we have to adjust with the extraction. And if you have a new version, you can also adjust the lordosis or kyphotic, the kyphotic position of the end plates according to your necessity. Next one. The limit is that really we have a blind sight medially, so we cannot control what happens in the midline. The space is very narrow and short, so the insertion of the cage is really demanding, and it's very important not to force the cage, but to prepare step by step, and in order to obtain laterally a space that you need and you require to position your cage. Finally, I think the limit is L5, because you have also always to control the sacral slope, because with the cages you are the limit of lordosis. So also if you can position it, in some cases it's not possible to have a proper angulation of the cage. So this L5 corpectomy by posterior approach may be not always possible with the cage that actually are on the market. In conclusion, the approach is really feasible. It's not easy, but allows us to have a reduction of surgical time, because we have not to change the position of the patient. We are working in a field that is very common for a spinal surgeon, because it's a poor posterior approach. So it's quite common, and for the starting of the approach is like a T-lip approach, an extraforaminal approach, so it's very common for us. And this is I don't know if you want to speak about the conclusion of the literature, Maurizio. Okay, this is some of the papers that are present in literature, a retrospective analysis. And you can see that in 3 years there are 10 consecutive cases in this retrospective, and also in the other are very few cases, because at the limitation, and so is a very strict indication of this approach. This is some other literature that you can find, and everybody said that is really possible, this approach. Have the limits, and the most risk is to have a dual disruption with the CF leakage due especially to the traction of the nerve root. This is our experience. You can see that in 2 years we had 29 patients, most in fractures, 17 and 12 tumors. And what we can see is about that we have 3 CF leakage and only 1 case of radicular weakness due to the retraction of the nerve root. The subsidence is another thing, because this cage have a limitation of the hand plate because it's not really very high like the hand plate, and with the over distraction of the cage you can have some subsidence, especially in not very good bone quality. Especially in older patients, you have to be very careful to perform distraction of the cage. And for tumor, the results are pretty similar to CF leakage with only 1 revision surgery, and the free subsidence also because in metastatic you are be very aware about the bone quality due to the metastatic progression. So it's really very strict indication in the tumor due to this fact. This is the first case that we have seen. This is the plan X-ray, and this is the final control. You can see here the area of the hemicorpectomy and of the pedunculotomy, and you can see how the cage is fit completely in the end plate. Obviously, in the trauma, you can leave half of the vertebra and to put some chips of bone to obtain fusion. That is the main topics of the trauma. And this is the X-ray that you can see that the cage is partially laterally but go over the midline. And this is the final control on the standing position. Other cases, another failure of posterior approach, so we go to the revision of the posterior approach and we put a cage by the same approach. This is a very complex fracture of T12 and L1 in a very young woman. It's very complex with hematoma. This was an emergency surgery, a very long construct because we removed 2 vertebral bodies and we reconstruct with the cage, and we perform a posterolateral and midline bone reconstruction with the air bones. This is a case of L5 metastasis, a single, yes, from breast cancer, young woman. The breast cancer was controlled, and this was the only metastasis. We can see that the sacral slope was not so evident, so in that case we perform the posterior approach and we position the cage on the opposite side in order to change the orientation of the hand plates to anchor the sacral slope. You can see in the CT that it fits to the sacrum. And this is another destructive angioma of a D5. So this is the reconstruction. The reduction of this type of fracture or pathological fracture may be performed with the screw and not with the expansion of the cage, because the cage have no enough strength, and if you force the cage, the risk is to have a subsidence of the upper or lower vertebral body. And this is our team. Thank you very much.
Thank you, Mauricio and Francesco. Really very nice technical details of difficult approach. First, I have questions from the participants. One is that Dr. Bayumi is asking, is it a unilateral transpedicular drilling?
Yes,
Do you mostly do unilateral drilling?
yes, we perform unilateral drilling of the pedicle as far as you want to remove the superior portion of the vertebral body. Afterwards, it's not just through the pedicle, of course, it's through also the lateral portion of the vertebral body. You have to get from one end plate to the other one. So the transpedicular portion of the remover will take place to achieve the upper end place.
But did you prefer also doing bilateral approaches?
Well, if you're dealing with a trauma, there is actually no need.
Or tumors?
With the tumor, if you're dealing with the tumor, if you want to achieve a large removal of the tumor, of course, you will go bilaterally. For instance, if you're dealing with a metastatic tumor and you want just to restore the stability, maybe you go by one side. The more you want to achieve tumor removal, the more you will go bilaterally, of course.
Okay. Again, Dr. Bayumi is asking, what do you mean by monolateral? Do you keep the spinous process intact and you go through hemilaminectomy?
It's what we have shown you. Maybe he made the question before, because sometimes there is no need at all. And if you want, we can go back to the slide. As a matter of fact, there is no need at all to expose contralaterally. This is not giving any advantage. Maybe this can give you an advantage if you're working in the lumbar spine, because you could even displace more the dural sac. But on the contrary, if you're working upper than L1, you will have no chance to displace the dural sac contralaterally. So there is no need really to have a bilateral exposure, because you cannot move the dural sac. In the lumbar spine, maybe that it can give you some advantage.
Okay. Dr. Korovesis is asking, how do you control the CSF leakage in the upper thoracic spine?
Well, first of all, if you're dealing with the spinal root, if you're tearing the spinal root, you're most using clips as far as the nearest as possible to the dural sac itself. If you're tearing it anteriorly, the only way is to position fat tissue. We are also using new sort of material, something as tacosil, for instance. But it's difficult to talk about something which is commercial. Well, there are plenty of things. For instance, this tacosil is something which is used by the thoracic surgeon to seal the pleura or even the venous vessel. And this is something which is really very, very effective if you want to stop a leakage if you have a tear in front in the anterior portion of the dural sac. Of course, it's something that you always hope will not happen, because the risk, of course, is to have then leakage within the thoracic cavity, which can even lead to death of the patient. We had a couple of cases not treated with this technique, just treating tumors, and it has been really a nightmare to treat it, because finally.
But what about? Sorry, we can skip that and ask you whether you use hypotensive anesthesia or not.
Hypotensive anesthesia, well, we used to operate as low as possible, but yes, not lower than 80 millimeters of mercury, because it's not really that you have a problem by the arterious bleeding. You're mostly in problem with the venous bleeding. The venous bleeding, we are using a lot yes, besides the hemostatic material, also
the glue.
No, l'examinocaproico. Ugurol. We are giving Ugurol, which is antifibrinolytic drug, epsilon-aminocaproic acid, and this is diminishing quite a lot the venous bleeding. We had the experience first in operating, in performing somatectomy in the cervical spine, and we transferred this experience when we are dealing with the extradural space in the thoracic and lumbar spine during this surgery, and it is effective. You have to start giving Ugurol before surgery and then giving again during surgery. You can even wash the operative field with saline together with Ugurol. This will help. As a hemostatic material for venous bleeding, by far the best in our hand has been what si chiama? Hemostatic. Avitene. I don't know what's the commercial name in the other countries. In Italy it's called as Avitene. It's fantastic.
Another question from Dr. Korovesis is that what is your preference to go to from right side or left side?
Si guarda l'anatomia.
If you're dealing with the trauma or tumor, of course you go by the side where the disease is.
Yeah.
We have no preference, as a matter of fact.
Okay.
Because you're not, it's quite different if you go anterolaterally, because in that case, in thoracic region, of course, it's more difficult to go by the left side. But if you're going posteriorly, there is no difference in the two sides.
So you can choose.
It's the disease itself that is giving you the proper side where to go.
Okay. Another question is, how do you avoid nerve root lesion in the lower lumbar spine during cage insertion?
Well, it's something that Dr. Costa mentioned before. First of all, you have to expose as far as laterally as you can the spinal root, because by this way you're reducing the angle that you're applying to this to the retraction. The second way is to position first the inferior portion of the cage as far as the root it's displaced, and then in an oblique way, by a subluxation of the cage itself, go up. So you start from where the danger is and then you go up, but rotating the cage in the proper position. Also, you can take a lot of advantage by this special spreader, which is applied directly to the screw's head. But I have to say something. The cage that we are showing you has a great advantage, which is the chance to change the lordotic curve of the superior plate when the cage is already in place. But the way you position it, it's not nice. This cage has not been designed to be positioned.
Under is outside and upper is outside.
Yes, you see in the picture that the inferior portion, here we are in the lumbar spine. You see that the inferior portion is already in place. And on the contrary, the superior one has still to be forced in. So you start from where the danger is. This cage has not been designed to be positioned by this way. It has been designed for anterior approach. Now we have shown you that many companies are studying different cages with this angled holder, which is allowing you to get underneath the dural sac in a more easy way. This one is very difficult. If you have a straight holder, it's very difficult. The one which is, can you show me the other one? We can show you the other one without any commercial indication. This one it's more easy to be positioned.
And it is similar to the instruments of T-leaf.
Yes, of course, it's something which is similar to the T-leaf holder, which is it's straight but something at the end, which is able to turn and position the cage underneath.
Dear friends, you have already mentioned, I know that, but one participant, Dr. Nilesh Mohan, is asking if there is a worsening of a nerve injury postoperatively. I think there was one case of L4 injury, is it?
Yes, there was one case of
slides.
F4 injuries, so, but you're not so worried because as, the femoral muscles has multiple root innervation. You can be really unlucky, and if the root is the dominant one, maybe you can have some weakness, but it will recover in some way. Of course, the one which is always crucial, there is a special work by some authors by some Indian authors about that. The crucial vertebral body in the lumbar spine is L5 because you need to, for positioning the cage, to displace L5, and there is no chance to have any recover of the strength of the tibial muscle if the damage is complete. But it did not happen. The first case we did was with a relative of one of the owner of the hospital. It's a private hospital, so it was scary, but finally we could accomplish without any deficit. Of course, the risk exists. You have to talk about that to the patient.
Another question. Is it applicable to the higher thoracic spine, or is it more difficult at that region? Upper thoracic spine.
We have done a couple of cases, even in the top area, which means T1 and T2, and it was not so difficult.
Post disease.
But in this case, you have a great advantage by the fact that you can section the rotor without any problem. So, and you can even use the remaining portion of the rotor to remove, to displace and rotate the dural sac. Of course, the size of the cage should be smaller, and we are using in this case cervical cage or cervical cage as well.
But what about post disease? Do you think it is also good? Post disease, tuberculosis.
I think I have not operated one. I think that Francesco has operated one.
Hello?
Yes.
Yes. Yes, in one case I operate a pod case. We don't know before that was a pod case. It was an emergency in a young man coming from India, but he had paraparesis, and we perform this approach without any problem of infection. So we removed completely the vertebra because I was thinking about a tumor. So I aggressively removed the vertebral body, and we perform the reconstruction as I show you with the foreskew on the top and on below levels, and with the cage.
Okay. My dear friend Abdul Hafiz is asking, how do you understand or realize the adequacy of decompression, especially on the ventral midline?
Oh, so in part I verify with the navigation. When I finish the decompression, we use the OR system, so I perform scanning, so I am able to verify with the intraoperative imaging if the decompression is enough. Otherwise, you can use some straight instrument just to verify if there is some bone in the midline, but it's a very blind angle, so you can feel with your instrument, but with the intraoperative imaging you can verify by a scanning of the case.
Do you think the navigation is mandatory?
I think it's very helpful. It's not mandatory because you can verify also with the X-ray and with the fluoroscopy, but especially at the beginning, where these angles are not really common in your hands, it's very useful to understand angulation, to verify really the depth of your corpectomy, and where when to stop your decompression. So in our case, in our institution, we use navigation in every case, and in that case I think is really useful, but not be necessarily mandatory. It's very, very useful, and I recommend to perform, especially at the beginning, with navigation.
Okay. How many levels do you prefer to fix after a corpectomy? In the upper level, lower level?
Okay.
How many levels do you fix?
Yes, at the beginning, at the beginning, I start with one level on the top and one level on the below, but in that case, I observe the some complication of subsidence. So right now, I perform 2 level above and 2 level on 2 level on the top and 2 level and below. But if in trauma, or if you have to perform 2 level of corpectomy, I prefer longer construct of 3 levels, but usually 2 level.
Okay. Another question, how much does one cage cost? What is the cost of a cage?
It's very expensive.
It's very expensive, yes. Yes,
Okay,
so
you cannot tell it. Okay, so no problem. Do you use microscope during surgery?
yes, always, all the time. Also because you use the high-speed drill, and you can have more control with the microscope for sure.
Okay. Do you have experience with tumor ablation devices in tumor cases?
Yes, but we don't use routinely, because we have some trouble with the hospital administration to obtain the machine to obtain tumor ablation. But yes, we perform, and we perform with navigation, and with the arm we really verify the positioning to obtain tumor ablation device, and after you can perform vertebroplasty in the area of tumor ablation. But they are really limited cases, I think.
Okay. Do you use intraoperative monitoring?
Yes, all the time, especially in the thoracic area, I use all the time the monitoring, but also in the lumbar spine, just to verify how the nerve root is, if the procedure is safe, if during retraction the nerve root gives some alteration of monitoring, we stop, we free in a better way the nerve root, or we gain some space laterally. So I think is mandatory to have intraoperative monitoring in these cases, in this approach.
Okay. Do you feel you are satisfied about the sagittal balance correction after surgery? And which measurements do you use, such as T1 tilt or C7 plumb line?
Yes, finally, yes, I'm satisfied. We start to study this patient with the EOS system, so with the teleradiography, and we perform the 3-dimensional reconstruction before and after surgery. And we use the C7 plumb line to define the sagittal balance.
C7 plumb line, okay. And probably one last question. Do you, after corpectomy with, after drilling, do you also use Kersons
Yes.
to remove the remaining parts?
Yes,
Probably,
I use Kerrison and biopsy, especially in the trauma, in order to preserve some bone for the fusion. And but it is useful also to reduce some in the midline, to reduce in the safer way the corpectomy, the area of the vertebra in the midline. So yes, I use it, and I use also biopsy.
Okay. One more question. Why do you avoid sacrificing nerve roots? I think not below, above T9.
But I think the limit where you have to stop to sacrifice is T12 L1. From T9, I think after some cases of experience you can avoid to sacrifice, but also upper to T9 right now I am feel about confidence to don't sacrifice, except for the upper, really in the upper thoracic spine. In that case you can it is better to sacrifice, but at the beginning in the thoracic area I sacrifice all the nerve root, stopping at T11, T12. Right now, I think with more experience in lateral preparation is not so necessary. So it's just
For instance,
a limit.
You have shown one case that you have done two-level corpectomy.
Yes.
Did you sacrifice the nerve root at that case?
Yes, in that case, yes, because it's quite impossible to position the cage inside the space without sacrificing in the middle nerve root.
Yeah, okay. Do you think, this is my question, is it like doing an osteotomy? There is some similarities of osteotomy approaches.
Yes.
What do you think about that?
Yes, finally it's an osteotomy. You can perform in different way, but you can perform with also with scalpel if you feel confident to perform a pedicle screw osteotomy, because it's quite similar, but after you have to go to complete the corpectomy, but to remove the pedicle and the initial part of the vertebral body you can perform as a standard osteotomy for sure. We prefer to use the high-speed drill. We are more confident with the high-speed drill than the scalpel, for example, but this is our use, so you can perform really. Yes, it's an habit for us, the use of high-speed drill, but if you perform with scalpel in the case of trauma, for example, you can preserve more bone for the fusion, so you have to consider for this.
One more question. Do we exercise the transverse process in the lumbar vertebra?
Yes, because it depends. It's not a rule to access the transverse process. If you can preserve the lateral part and to preserve the transverse process is better, but you can remove it or without any problem. So it depends from the anatomy, I think, and from the anatomy of the nerve root, because your lateral space depends from the nerve root. If is horizontal, if is very slightly oblique, it depends from this.
Okay. One person is asking what is the difference between this approach and the vertebral column resection. What is the difference in between? This is not a vertebral column resection, I think.
No.
We must not call this approach.
Yes. If you have to perform en bloc resection, you cannot perform with this approach because you are not able to rotate the vertebra. So
to detach.
Yes, to detach anteriorly the dura and the ligamentum. So this is a partial corpectomy. So are two different fields. From a biomechanical point of view, the results are similar, but the indications are completely different.
Okay. Yeah, I really congratulate you that because I see your numbers on bleeding. It is about 800 milliliters, which is quite less than many pedicle subtraction osteotomies. In the reports, I've seen 1,500 milliliters bleeding in those cases. It was a great presentation. Thank you a lot.
Thank you very much.
I think we can finish it here.
Yes, I thank Dr. Maurizio Fornari for final.
Okay, Mehmet. Finally, we have been able to do it. Finally, it's very nice. I like it. And
Yeah.
let us know
Enjoyable talk
when
and
there will be the next webinar. I profit by the fact that I'm speaking with you directly. Do you made a choice about the date of the biannual meeting?
yes.
Which is the date
The date
of the biannual meeting of the spinal committee?
the annual meeting will be in 2020, I think.
Yes, but did you already choose even a month? We were thinking about October, for instance.
Yeah, this is fine.
Okay.
This is perfect time.
So I
Yeah.
will send you some
Good.
proposal about the possible date. Okay. So
Good. Very nice.
according to other congress and your personal business and so on.
Thank you. Thank you.
So thank you for
Thank
the
you.
chance
Wish
you
to see
gave
you
us.
again.
See you soon.
Yeah,
Bye bye.
See you.
Say bye bye to
Goodbye.
Berna
Goodbye.
also. Bye bye to Berna. Bye bye.
Thank you. She is also having her greetings. Thank you. Goodbye.
Interrompere tutto.